Welcome back to Rebelcast. I'm your host, Salim Rizai. This is episode 126. The title, Should We Not Be Recommending Small Adult Bag Valve Mass in Out-of-Hospital Cardiac Arrest? I know that's a mouthful, but this is a paper that came out back in, I believe it was November or December of 2023 that I've been wanting to tackle, and finally I got to it. And basically we know in out-of-hospital cardiac arrest, we care about ROSC, we care about survival, but what we really care about the most is survival with good neurologic outcomes. And the only two interventions over and over and over again that have shown this reproducibly are high-quality CPR with minimal interruptions and defibrillating patients early that have shockable rhythms. We talk much less about ventilation strategies in these patients, but it's still an important component of resuscitation. And we know that giving too much minute ventilation to these patients can have untoward physiologic effects, like increasing intrathoracic pressure, which could potentially decrease venous return and therefore cardiac output. We could lower CO2 levels to a point when we hyperventilate these patients that we start getting cerebral vasoconstriction, which can cause secondary brain injury to an already ischemic brain. And most organizations, when you look it up, and I'm not going to go into the specifics here, but they recommend anywhere from 500 to 600 mLs per breath during ongoing CPR. Now, large adult bag valve masks have a maximum tidal volume of about 1,500 to 2,000 mLs, depending on what brand you have. And with one-handed ventilation, and simulation studies have shown this, we're delivering about 750 mLs, which is much greater than that 500 to 600 mLs that is recommended. So one of the things people recommend is maybe we should just be using smaller BVMs. Well, I'm going to stop right there because I've gone too far. I need to introduce my partner in crime, the buttery smooth Swami. Swami, I know you looked at this paper and you were kind of like, what a mess. And I felt like, you know what? This is the perfect type of paper to discuss in a podcast. So welcome. And
it's a bit of a mess.
Yeah, I'd love to just hear what you think.
The paper's a bit of a mess, but it's got an impact because people read resuscitation, they look at these articles, and then they want to apply them to practice. We just have to be a little bit cautious because resuscitation tends to not necessarily publish the highest quality, best methodology. And I think that's exactly what we have. We don't have a great study looking at these small adult BVMs. And this one doesn't really help us that much, but I think it's important for us to get into why it doesn't help us that much and what they did actually look at and what they found.
So the paper we're talking about is Snyder, BD et al., Association of Small Adult Ventilation Bags with Return of Spontaneous Circulation in Out-of-Hospital Cardiac Arrest, published in Resuscitation 2023. And the clinical question these authors were trying to answer is large adult BVM or small adult BVM associated with more ROSC in adult patients treated with advanced airway placement for non-traumatic out-of-hospital cardiac arrest? Swami, in a nutshell, what did these authors do?
This was a retrospective observational cohort analysis of prospectively obtained data from a single urban EMS system. They basically looked at which of these devices was going to be better. And it's really a before and after kind of collection. So they changed from the large adult BVMs to small adult BVMs in about 2017. There was a bit of a crossover period, but essentially it's a before and after. We used the big ones, then we changed to the small ones, and we looked at the data before and after that change.
That's exactly it. And the primary outcome was, as already alluded to, ROSC at the end of EMS care, which they defined as arrival to an emergency department or terminated efforts in the field. And then the key secondary outcomes were ventilation rate and mean end tidal CO2 during CPR. As far as inclusion, these were adult patients with non-traumatic out-of-hospital cardiac arrest, and they had to be treated with an advanced airway, which they defined as either an endotracheal tube or one of those eye gels. There was nothing else that was allowed in this study. It had to be one of these two. I will list all the exclusion criteria, which I felt like were pretty status quo for this type of study. And Swami, let's get into the results.
So overall, they had 2,000 patients that were in this data set. 67% of these were treated in the after period, so with the small adult BVM, 33% with the large adult BVM, about 20% had an initial shockable rhythm. And when looking at their big outcome, ROSC, in this small adult BVM group, it was 33%. In the large group, it was 40%. That's a 7% difference. That was statistically significant, favoring the large adult BVM. And Salim, I'm a little surprised by those results. And that's exactly why we wanted to get into this, because I think when you look at those results on the face of it, what it tells you is it doesn't really matter what we use. There's no reason to switch over. Just go ahead and use the large BVMs in spite of the fact that we are delivering larger breaths. At least that's what it insinuates, but we'll get into what it actually means.
And then when we look at the ventilation rates, there was really no difference between groups. They were ventilating these patients at the same rate, 12 breaths per minute. And there was a slight, ever so slight difference in end tidal CO2 numbers, with the small adult BVM being slightly higher and the large adult BVM being slightly lower, which we're not surprised by. Now, we'll list all the strengths and limitations because there was a lot of them, but I really want to jump to the discussion, Swami. And the first thing I want to get into, and I'd love to get your thoughts on this, is that when you do a before and after study, and it's not really a true randomized clinical trial, there's going to be baseline differences between the two groups. Things just change over time. It's what happens. And there were a ton of confounders in this study, and the authors did the best job that they could to basically balance for these two things. Although I would say that when you look at most of these things, they kind of favored more ROSC in the small adult BVM mask group, but that's not the way the study came out. But then what you have to keep in mind is, what was the quality of the CPR between the two time periods? What ACLS meds were given between the two time periods? Were there reversible causes of a heterogeneous disease process that were completely a reversible thing, like tension pneumothorax or tamponade? There's just so many other confounders that make this so messy that I don't know what to do other than say, like, yep, they did this before and after thing, and they showed the small adult BVMs did worse, but there's so many things that they didn't basically account for. I don't know what your thoughts are on that, but that alone kind of makes this a sloppy trial.
Yeah, I mean, before and after studies are always just, there's so many different reasons you have to take into account other differences. So were there changes in the way that we performed CPR? Were there changes in the way that things were being delivered, in resources that were available? There are a lot of those things that come into play. And one of the big ones is the fact that the end of this trial, when they were using the smaller adult BVMs, happened during the COVID-19 pandemic. And you and I know the way that we provided care to cardiac arrest patients during that time period was vastly different than the way we provided care outside of that pandemic. And that might make a massive difference in the outcomes. And that's why before and after studies aren't great. Now, it's fine to say that the study methodology isn't strong. What's even more important is to say, how could you do this better? So if we want to get a real study looking at this, how do we do it? I think you take multiple EMS systems and you randomize them to either the adult size, to either the large adult or the small adult BVM. And then you could get some real, it's not truly randomized control data, but it's pretty close. And it would give us a much better estimate of what's superior, what's not. The other thing, and we'll come back to some of these shortcomings, but the other thing that I think really should be pointed out as well is that we are looking for a relatively small intervention to have a big impact on patient outcomes. And that's pretty hard. I mean, whether you use the small or the large BVM, is that really enough to change the outcome of ROSC? That's pretty hard.
Yeah, I don't disagree. I mean, so listen, people come out with these, like experts, come out with these recommendations like, hey, we're overinflating the lungs, we're increasing intrathoracic pressure, we're blowing out the alveoli, we're doing all these terrible things with these large BVMs, so we should go to a smaller one. And then you get these simulation studies that say like, yeah, we are giving these larger volumes. But then what that translates to in actual patient care, I think is important. And I think the one thing this study does tell me is that when we make these recommendations, there's a flip side to using a small adult BVM mask. And that is that we could just be hypoventilating people. We could be increasing dead space fraction. We could be de-recruiting alveoli. We could be causing more atelectasis, which can cause shunt physiology. all of which I think are equally as bad as overinflating the lungs. And so this is why it's important to study this stuff. I don't think this trial, though, gives us that answer. It just says, like, hey, hold your brakes a little bit. If you're switching over to a small adult BVM, maybe not. Maybe we need a better study before we actually make that implementation, because like you said, one small change in one system might not be that big. But now imagine if you do that globally with all the cardiac arrests that happen all over the world, and it really has this bad impact. We're killing more people by doing this thing because this is what the experts told us to do.
Yeah. I think you're right. I think if we're gonna really do a big switch to a different device, we really should have some efficacy data showing it. Again, physiologically, this all makes sense. I don't really understand why the adult bag valve mask reservoir has 1,500 cc's. Nobody needs that volume, but nobody gets that volume either. We know nobody gets 1,500 cc's. They get something less than that, but you're right. We need a real study. This should simply be hypothesis generating. It should simply be, hey, listen, we need a real study. We need a good, high quality methodology study looking at this question so we can really get an answer. And we just don't have that data at this point. So I think what it tells me is I'm not going to switch. At the same time, though, I think it's important for us to understand how best to deliver those breaths using a bag valve mask. And it really is not to squeeze that thing all the way down because it's just too much volume. And this might also speak, Salim, to why using a vent to do your breaths during cardiac arrest might actually be better. We have some data on that. We don't have a ton of data. And clearly, we're not going to have a vent on the ambulance that can do all of those things. So there's a lot of things to work with. We need better studies. This isn't it, but at least this makes us question the idea and then go out and get better data.
So this is what the authors concluded, Swami, and then I'm going to let you take us home. I'm going to quote them here. Use of small adult bag during out-of-hospital cardiac arrest was associated with lower odds of ROSC at the end of EMS care. The effects on acid-base status, hemodynamics, and delivered minute ventilation remain unclear and warrant additional study.
I think that's a very reasonable conclusion to draw from the data they have. Our conclusion runs along the same lines. This is a messy trial with lots of methodologic and confounding issues that make it difficult to interpret. It does show that when experts recommend an intervention, it's important to study it. Until better evidence shows us differently, it's probably okay to stick with the BVM that you're currently using, but make sure that you are not cranking down on that thing and maintain a rate of 10 breaths per minute.
And there you have it, Rebelcast listeners. Let us know your thoughts, comments, and questions. And as always, until next time.